Good afternoon, and thank you. My name is Vicki Hensley. I'm from the University of Kentucky, and I would like to present just a short overview of bullying and then present some current research that I have done involving healthcare providers and their feelings and attitudes and thoughts about bullying and whether or not they are assessing for bullying. So childhood bullying is a serious problem that was mentioned earlier that adversely affects lots of youths around the country. It affects up to about over 30% of youths, and it is accounted for 160,000 missed school days a year. There's lots of negative consequences of bullying, including depression, negative emotions, self-harm, suicide, anxiety, bedwetting. The bully also experiences negative effects such as an increased likelihood of theft and violence and binge drinking, and it actually leads to inflammation in the body. So there's some new research that's linking higher CRP levels and even bullying years before in youth. There are many national agencies, including the American Academy of Pediatrics, the Society of Adolescent Medicine, and the National Center of Mental Health Promotion and Youth Violence, that encourages healthcare providers to take an active role in bullying. However, when looking at the literature, it focuses around the consequences of bullying and the percentage of those being bullying. Very few research is actually focusing on the role of healthcare providers. So I wanted to explore that a little bit more and did some research about that last year. The specific aims of this research that I'm going to talk about is to examine the current practices, attitudes, confidence level, and knowledge of nurse practitioners and physicians regarding bullying and assessing for bullying. And then what were the differences in the current practices regarding the assessment of bullying based on attitudes, their confidence level, and their knowledge. And then what's the predictability of the attitude, self-efficacy, and knowledge of bullying on the practices of healthcare providers. So a descriptive cross-sectional study was designed, and a physician or nurse practitioner who worked in Kentucky who conducted a well-child exam at least weekly were eligible to participate. And then data was collected with an instrument called the HCP pack, which contains 6 sections. It contains a demographic section, a assessment practice section, a section on attitude, self-efficacy, and knowledge, and then a last section just about training needs that they view as important. The study variables included attitudes, self-efficacy, and knowledge, and specifically I looked at how those tied together to affect bullying assessment practices. So our B approval was obtained, packets were mailed out. When they returned their packet, that was considered their informed consent. 118 completed questionnaires were received back. They got a $10 gift card for completing the packet, and then data was entered into SPSS and analyzed. Briefly, just a general overview, about 62% of the return questionnaires were from physicians. They were, on average, 17.5 years as a healthcare provider. Most of the respondents were female, and 72% were in a private practice versus a community health setting. Less than half of the people that returned questionnaires were assessing for bullying. This did not surprise me. I've worked as a pediatric nurse practitioner, and even when I was working, I was not assessing for bullying. Why they do assess for bullying, some reasons listed were agency recommendations. They feel it's important, and they were seeing bullying among the population that they were seeing, and then the belief that bullying is important. Some reasons why they listed that they were not assessing for bullying was the lack of time. You know, you've got 20 minutes to completely do a physical assessment, and bullying's not the top of your list, so you run out of time to ask all those necessary questions. And then the well-child templates that most facilities use don't include questions to ask. So oftentimes before a child is seen for a well-child visit, the parents will fill out just general questions, and it's not on the template to ask about. Some descriptive statistics included of the study variables. The mean scores of all of the study variables, attitude, self-efficacy, and knowledge, were pretty low. So obviously there can be lots of improvement regarding attitudes of assessing for bullying, the belief that they are able to assess for bullying, and then just general knowledge about bullying. I divided the respondents into two groups, those that assess for bullying and those that don't assess for bullying. And then I examined the differences based upon the study variables. And what I found was there were little meaningful differences between the mean scores of all the variables, between those who assessed for bullying and those who did not assess for bullying. Even though there's a significant difference, it's just not very meaningful. So I took it a step further, and I performed a logistic regression to look at the impact of the years as a healthcare provider, their role, the attitude, self-efficacy, and knowledge score, as well as if their workplace policy would influence whether or not they assess for bullying. So the full model was significant, meaning that that the model as a whole explained about 16 to 21% of the variance in bullying assessment practices, and it correctly classified about 69% of the cases. The strongest predictor of reporting for bullying was attitudes, with an odds ratio of 1.24, and this means that for every 1 unit increase in attitudes, the likelihood that someone assessed for bullying will be 24% higher. And then self-efficacy was also a positive predictor, and that had an odds ratio of 1.18, meaning that for every 1 unit increase in self-efficacy, the odds of assessing for bullying were 18% higher. So the key findings are less than half of the healthcare respondents or providers that returned a questionnaire were assessing for bullying. This is huge for me. A simple question of, are you involved in bullying? Does anyone pick on you at school? Is very important. We need to be asking the question. We need to be talking to children about it. I've had many, many stories of, I had no idea my child was bullying. Others are being bullied. I had no idea to even ask. So just a healthcare provider that the child has a trusting relationship with asking about bullying can mean the difference. And then the other thing that was found with the study was that the provider's attitudes and self-efficacy are positively associated with whether or not healthcare providers assess their patients for bullying behavior. So the better attitudes that the healthcare provider will have, as well as a better belief and a belief about themselves that they can ask about bullying, influences whether or not a healthcare provider will ask about bullying. Limitations were the tool used to gather the information has limited reliability and validity, and then the response rate for the whole study was only 28.3%. So in conclusion, healthcare providers should be encouraged to take a more active role in assessing their pediatric patients for bullying. I think one other reason that we don't often ask about bullying is we don't know what to do if the person comes back and says, yes, I am being bullied. There's lots of easy things you can do. You can refer them to a guidance counselor. You can refer them for counseling. You can just open up the door for conversations with their parents and give them some empowerment of what to do at school. If a child is actually bullying others, you can then discuss why they need to do that and talk to them, try to instill some empathy with them and help them realize the implications of that. Training can be provided to healthcare providers to increase their attitudes and self-efficacy and knowledge. And then more studies need to be done on this. Lots and lots of things can be done. One thing that I would like to do is just expand the same study on a larger scale. We need more than 118 respondents to actually extrapolate the information and design some interventions that will increase a healthcare provider's self-efficacy and knowledge and attitudes. Any questions? Yes?
In different parts of the country?
You know, the research that I've seen, it really doesn't. So I've looked at studies from Switzerland. Lots of studies have been done overseas, and the percentages ranges from about 25 to about 34. So yes, there is some variability, but it's universal. Yeah, it's everywhere. Yes.
I didn't quite hear what you were saying about the bullier. What are some characteristics of the person who's doing the bullying that could be changed?
So someone that bullies others I don't know that there are some general characteristics of a bullier. They often are doing it just to empower themselves to pick on someone else. And the bully is where most research is, and that they are different somehow, either health-wise or physical-wise. They may be considered a geek or a nerd, if you could use those terms. So someone that's picking on others usually gets attention from others, and they want to build themselves up. As far as what can be done, guidance counselors and counseling, talking to them, instilling some empathy for others, some role playing, and helping them just realize what they're doing.
Is there any indication that their home environment might not be?
Yes, so the home environment has played an influence. So those that are exposed to violence at home are more likely to bully. Those that are exposed to like video game violence on a repeated basis are more likely to bully. So yes. It's a huge problem, and we don't exactly know what to do with it. The school intervention programs that have been designed are not great. They're not a huge success. And so opening the door for healthcare providers, nurses, physicians, nurse practitioners to ask about it and open a dialogue is just another avenue that we can step in and help.
I think that's so important, because when I was talking, I talked about the two girls who committed suicide in your county last week. They were both bullied, but I didn't want to say that.
Yes. Yeah.
But they were both bullied. They were from the same school district, went to the same high school. I don't know if they knew each other.
Sure.
But both were bullied, and their suicide notes gave that as a rationale.
Right. Right. It's very sad, and to think that it can be prevented, it's unnecessary, but those girls may not have opened up to anyone. And so a question that I've had is, why do you think students, children, would open up when they've not talked to anyone else? Well, healthcare providers have that very trusting relationship. It's a confidential setting, so they may feel more comfortable talking to a healthcare provider when they've talked to no one else. So, anything else? Thank you.